Hi everyone, we'll get started here today. My name is Helena Mistry and I'm the Director of Business Development for IMICA. Today's speaker is Dr. Sami Obaid, and the title of our webinar today is Utility of Tractography and Connectomics in Neurosurgery, Why Tracking Matters. Today, Sami will give a 35-minute presentation, and this will be followed by 20 minutes of Q&A. So the total of our webinar today will be 55 minutes. After his presentation, if you want to ask any questions, please feel free to do so by clicking on the raise hand icon and I will unmute you and allow you to ask Sami a question. Alternatively, you can type it into the question box and I'll read it out to him. After the webinar, we'll follow up with a very brief questionnaire. I promise it's not, long. And so if you fill that out, that really helps us with future webinars. And lastly, we'll be recording today's webinar. So a little summary about today's webinar. The use of DWI-derived tractography has recently emerged as a novel technique to guide surgical resections in epilepsy and oncological neurosurgery. Tractography is a useful adjunct in localizing white matter tracts intraoperatively and allowing sparing of functional connections in both tumor-related and epilepsy surgeries. Tractography-derived connectomics constitutes an emerging and promising tool that allows us to characterize whole brain networks, which are potentially disturbed by neurological diseases, including epilepsy. In this webinar, various perioperative applications of tractography and connectomics in epilepsy and oncology neurosurgery will be reviewed, with a special focus on the use of such modern tools in diagnostics and surgical epilepsy. The utility of connectomics in identifying structurally remodeled tracts to be targeted during surgical resections of patients with focal epilepsy will also be discussed, with the goal of optimizing seizure control. A little bit about our speaker today. After graduating from McGill Medical School in 2012, Sami completed his postgraduate residency training in neurosurgery at Université de Montreal in 2019. He currently practices as a fully licensed neurosurgeon and will undergo a subspecialty fellowship training in epilepsy neurosurgery at Yale New Haven Hospital, starting in July of this year. In parallel, he is currently completing a PhD in neuroscience at Université de Montréal and working on tractography-derived connectomics and insular epilepsy in the Sherbrooke Imaging Connectivity Lab. His work on neurodegenerative diseases, which began when he was a teenager, was awarded many awards, including the Canadian Top 20 Under 20 Award, a Certificate of Distinguished Citizen of Canada, the Personality of the Week in the provincial newspaper La Presse, and a Main Belt asteroid named after himself, awarded by the Lincoln Laboratory of MIT. Okay, Sami, I will turn it over to you.
All right. So thank you for the very kind introduction, and especially thank you for the invitation today. So as Elena mentioned, I'm currently working at Maxime Descoteaux's lab. So Maxime Descoteaux is the CSO of IMICA, and it's a real privilege to be able to learn from his team's expertise on tractography and connectomics. He's a really important mentor to me, and I truly appreciate our interactions. So I'm very honored today to be here and give this talk. I hope you enjoy it, and I look forward to the discussion afterwards. So let me just start sharing my slides. So I do not have any conflicts of interest. So what are the challenges in neurosurgery? So in neurosurgery, we always try to balance between having an optimal resection, whether it's cortical resection for epilepsy purposes or tumor resection for oncology purposes. But at the same time, we have to balance it over preservation of neurological function. So obviously we can remove more cortex or more tumor and try to lead to seizure freedom or more tumor resected. However, you obviously do not want to injure the patient and result in neurological complication and deficits. So we're always stuck between those two principles. We do have some tools, so neurosurgical tools that can help us in achieving both goals. So we have imaging studies, we have intraoperative adjuncts, we have invasive investigations. So all these tools are very useful, but unfortunately they're imperfect. So we can ask the question if diffusion MRI tractography or connectomics, which is basically the study of the connections within the brain, can be helpful in neurosurgery. So I'm basically going to talk about a few things today, including diffusion MRI tractography and the basic principle of a diffusion MRI tractography. I'm going to talk about the utility of tractography in oncology neurosurgery, in localizing the epileptic foci, in other words, in diagnostic epilepsy, and also in epilepsy neurosurgery. So just the basic principle of diffusion MRI and tractography. So what is isotropic diffusion? It's basically the diffusion of molecules due to random Brownian movement in all directions. So as you can see, it's illustrated here. And when you don't have any physical barrier, molecules, for example, molecules of water, can diffuse in all directions, as illustrated by this sphere here. However, anisotropic diffusion is basically diffusion oriented towards a certain trajectory, a certain direction, due to the restriction of movement in other directions. So it's restricted perpendicularly, but it's allowed in parallel to the actual physical barrier. In our case, the physical barrier or the neuronal axons, as illustrated here in this small diagram. So let's say we have this specific example of axons that are crossing. We're able to model these axonal bundles with what we call fiber ODFs. So basically fiber orientation diffusion function. And you can see here this little cross actually illustrates both bundles of axons that are perpendicular to each other. If you look at the bottom screen here, starting from diffusion MRI images, so signal, we're able to model the FODF fields, meaning in every single voxel, you have this little FODFs that models with the direction of the axons. And we're then able to track, so to recreate the tracks on top of using these FODF signals and try to represent anatomy the best way possible. So using these specific techniques, we're able to build what we call a tractogram, which is basically all the tracts within the brain. So we're able to represent it and to actually analyze the white matter tracts in the brain. What we can then do is take the whole cortex, and using specific atlases, we're able to divide the cortex in small parcels. And then using these parcels and the tractogram, build what we call a connectivity matrix, which is basically here on the x-axis, you see all the cortical subdivision represented, and on the y-axis, all the cortical subdivision also represented. And every single point within the matrix represents the connection between both cortical region. You can also illustrate connectivity matrix in a more of an illustration, such as a connectome. So basically it's the same thing, but you're actually showing the connection instead of showing it in a matrix. So what are the applications in oncology neurosurgery? So this is a good paper that was written by David Fortin and Maxime Descoteau's team at Sherbrooke. As you can see here in this specific illustration, we were able, using diffusion MRI tractography, to identify functional tracts. So here you can see here the functional tracts here around the tumors, and then by looking or by knowing where the tracts are, you're able to identify the tumor and make sure you don't disconnect those tracts. It's also very useful to plan the surgical entry point. So basically you see here a tumor on an MRI that's represented by purple here, and you see the cingulum that has been tracked. As you can see here, the cingulum on the left side is laterally displaced, and therefore an approach through this more of a medial and superior approach was chosen in order to spare the cingulum and try to preserve this functional tract in order to preserve neurological function. Here's another example of how to preserve functional tract. That's a very interesting article that was published a few years ago. The frontal isthmian tract is basically a tract that connects both regions of the front, two regions of the frontal lobe that are involved in speech or language production. And by using the diffusion MRI tractography images, you can actually integrate it into the neuronavigation system, which is a GPS that we use during the surgery, so intraoperatively. And we're then able to track, using cortical stimulation in awake surgeries, we can look at the diffusion MRI signal and try to stimulate different portion of where we would be expected to find a tract. And actually, from a functional standpoint, by seeing the results or the functional changes that the patient presents, actually make sure that this actual tract is located where we think it is located based on the diffusion MRI tractography. So it allows us to optimize tumoral resection, but at the same time preserve the important functional tracts. It's also extremely interesting in planning the surgical entry point. As you can see here, which is very interesting in this paper, this is a very basic RGB map based on the principal direction of using DTI, diffusion tensor imaging. So this is a very basic image, but you can see that the cortical spinal tracts, or I should say the internal capsule, is displaced laterally, and therefore the surgeon decided or chose more of a superior approach to target the actual lesion and try to spare such functional tracts. So what are the advantages of what we call FODF tracking? So fiber orientation diffusion, fiber tracking, function tracking, sorry. So instead of using instead of tracking on DTI, we can track on a more sophisticated model, namely the FODFs, which allows a more accurate representation of the fibers. So let's say we start with this, a population of fibers, of crossing fibers with two different directions. So these are two different population of axons represented by two different directions. Using classical DTI tracking, which is based on the model of a tensor, only one direction of fibers can be modeled, which is based on the average signal of both fiber population. In FODF tracking, which can be performed using Maxime Descoteaux's algorithm and is also available at IMECA, both directions can be modeled, and therefore the crossing of fibers can be obtained in the final tractogram thanks to the multiple directional diffusion images acquired in the acquisition phase to build it. So as you can see, the difference between FODF tracking on the left side and diffusion tensor imaging tracking on the right. So using FODF tracking, the corpus callosum is way more filled and more precise anatomically, as it can take into account both crossing fibers as well as fanning of fibers, which is not the case in DTI, where you see this very thin bundle that doesn't take into account the crossing or highly curved tracts. It's also extremely interesting in peritumoral edema, so edema around tumors that's represented by the green on both images here. So peritumoral edema is basically normal, non-pathological region, or normal non-pathological region that contains only swelling, so basically water. So you would expect white matter fibers to go through that region, and we know that anatomically speaking, white matter tracts are present in this region. So using classical DTI, not only do you only have one direction per voxel, as previously mentioned, but the tracking is based on FA thresholds. So basically, tracking around or to the edema would actually stop as soon as it reaches the edema, and you won't be able to see any tracts going through the edema. In FODF tracking, not only can track with some specific algorithm, you can go through the edema, but also every single voxel is more accurately represented in terms of signal, and you can model crossing fibers, curved fibers, and so on. So it's definitely more accurate for these cases. You see these images here at the bottom. You see two types of local tracking algorithms on the left and right, and you can see that not only the bundles are more accurately represented with some fanning and are more anatomically precise, but also you see that the fibers go around the tumors and penetrate, I should say around the tumor, and also penetrate the edema. However, using classical DTI tracking, you see that the tracts are not as well represented in terms of anatomy, but also it does not go around the tumor and does not penetrate the edema. So you see the limitation. So we have to know, however, that there is some limitation of diffusion MRI tractography. So it can give a false security in the operating room, because you cannot only rely on what the images show you. You need to rely on the anatomy that you know, and also you need to stimulate cortically the specific tracts and observe specific changes in the patients during awake surgery to make sure that you're actually identifying the functional tract you're looking for. can also reconstruct false anatomy, especially with more sophisticated tracking algorithms, such as on the FODF tracking. There's more directions to choose from, so you can have some false positives. In some cases, especially with DTI tracking, you can underestimate the bundle volume. So during the surgery, you might think that you haven't reached the tract or the actual bundle, but it might not be the case, and you might be within the bundle already. And obviously, it's sensitive to the parameters chosen by the user and the type of tracking algorithm as well that is chosen. Nevertheless, some studies have shown that there's improvement in clinical outcome in patients using diffusion MRI-based neuronavigation systems. There's a very interesting randomized control trial for patients with gliomas that involve pyramidal tracts, in other words, motor tracts, that was published in 2007. Although the technique for tractography, the tracking algorithm was a pretty old tracking algorithm using DTI, they showed that they were able to achieve more extended resection and higher survival in patients using neuronavigation system that integrated DTI tracking. They had twice as more patients with gross total resection in the group that was actually using diffusion tensor imaging neuronavigation system. And the median survival for high-grade gliomas was also significantly better with patients that actually use tractography-based neuronavigation system. Even in terms of preservation of function, in this specific paper, there was less motor deterioration, in patients using DTI-based neuronavigation, as opposed to patients not using it. So I'm going to show you a surgical video. So if ever you're sensitive to blood or surgical anatomy, please feel free to skip the following section. So this is a case that I operated, a patient that I operated last week. It's these are 30-year-old right-handed man, perfectly healthy, but that developed the right-sided homonymous immunopsia, meaning contralaterals on the opposite side visual field deficit due to the tumor. So as you can see, the axial MRI showing the tumor within the atrium. So atrium is a part of the lateral ventricle, and you can see the tumor that enhances following gadolinium injection. It's a pretty voluminous tumor for the location. You can see the sagittal image again. We're able to track the optic radiation, the inferior portion of the optic radiation, which was located lateral to the atrium of the ventricle, and the inferior frontal occipital fasciculus, which was also located lateral to the ventricle. And for that reason, we chose more of a superior and median approach in order to spare both tracts. So more of a medial approach through the superior parietal lobule. So the patient was positioned laterally with the head rotated down. You can see the incision that's planned. Here you see the surgical drapes that are installed, the craniotomy, meaning removal of the bone, the opening of the dura, and the cortex that's illustrated here. Here's the cortical incision that I performed based on the neuronavigation tracking. You see here I start dissect the tumors here in yellow, which appear to be small initially. You see the dissection using suction and micro scissors. So I'm able to disconnect the tumor from the normal anatomy. You see the tumor here. I'm coagulating the vascular pedicle, meaning the vessel that actually feed the tumor. And I'm cutting this vascular pedicle in order to decrease the feeders or the vascular supply. Here you can see that everything that's under my micro scissors is actually the big tumor, which is about 4 centimeters in length. And I'm clearly dissecting the tumor from the normal anatomy around the tumor. So I'm creating a plane. You see a large vein here, trying to preserve. I'm mobilizing the tumor using a hook. I'm again coagulating the interface between the tumor on the left side and the normal anatomy on the right side within the ventricle. You see that I'm sparing again the vein that's located on the right-hand side, because obviously this can lead to cortical venous infarcts in some cases. I'm dissecting and cutting at the intersection. And I'm verifying every time I do a surgical step, just verifying that there's no complication. As you can see, it is not the case. You see at the end the vein and vessel that are preserved and the tumor is completely removed. This is the postoperative MRI showing the entry point, which was medial and superior through the superior parietal lobule. There was no residual tumor following the surgery. The patient after the surgery improved in terms of his visual field deficit, but developed transient word-finding difficulties that resolve within a few days. So what are the applications in diagnostic epilepsy? So epilepsy is a pathology that's due to synchronized abnormal neuronal discharges coming from the cortex. And focal epilepsy is now increasingly recognized as a network disorder and not as a specific cortical focus, but rather a connection of different cortical regions through a white matter network that's hyper-connected. So basically, there's hyperconnections between different regions of the cortex within a specific area. And that's what represents the epileptogenic network. So recognition of the network to localize the epileptogenic trigger is very important. And recognition of the network to orient treatment is also very important. So previous studies have shown that structural connectivity in focal epilepsies, not necessarily specific type of epilepsy, but an epilepsy coming from a specific region, that you have increased connectivity within the epileptogenic zone or regions related to early spread of epilepsy. So epilepsy can spread from one region to another. This is just a simple paper that was published in 2015 that showed that there was increased connectivity in temporal limbic regions in patients with temporal lobe epilepsy. Patients that had a network within the temporal lobe had hyperconnection within those regions, the temporal lobe and the limbic region. And the limbic region is known to be part of the epileptogenic network of temporal lobe epilepsy. Hence, it makes sense to see that hyperconnection in these patients, specifically in those regions. I personally have a specific interest for what we call insular epilepsy. So it's seizure originating from a deeply located structure, namely the insula, which is considered the fifth lobe of the brain and is embedded within the frontal, parietal, and temporal lobes. We need to lift those lobes in order to access the insula that's deeply located. The insula is very connected both to the frontal lobe, parietal lobe, and temporal lobe. And therefore, it's very difficult, clinically speaking, to identify a patient with a seizure that comes from the insula because he can present with specific symptoms and features that can mimic frontal lobe, parietal lobe, or temporal lobe epilepsy. So it has what we call a very diverse semiology, so diverse clinical characteristics. And again, it can mimic temporal lobe epilepsy with visceral sensory symptoms, can mimic parietal lobe epilepsy, or it can mimic a frontal lobe epilepsy as well. So as mentioned, it has a very diverse semiology, in other words, clinical characteristics, and can mimic frontal, parietal, but mainly temporal lobe epilepsy because it's so closely related anatomically, and the actual clinical symptoms can be very similar. So it's very difficult to establish a diagnosis clinically and radiologically of insular epilepsy. So what we did with Maxime Descoteaux's team, that was a few years ago, we actually performed an analysis of cortical thickness in patients that had opercular insular epilepsy, which is a form of insular epilepsy that also includes a small part that covers the insula and is often considered part of the insular epilepsy network. When we compared patients that had opercular insular epilepsy to patients that had temporal lobe epilepsy, both ipsilaterally and contralaterally, we saw that there was more of a widespread pattern of cortical atrophy in patients with insular epilepsy as compared to patients with temporal lobe epilepsy. And this makes sense because we know that the insula is so vastly connected, and we expect its network to also be vaster than the network of temporal lobe epilepsy. And hyperconnection actually leads to a pathological cortical thinning in regions that are hyperconnected. And this is what we observed in that paper. It was very interesting because we suggested that it could be a potential tool to differentiate both types of epilepsies that are so similar, both clinically and radiologically. So the goal of the project that I'm currently performing with Maxime Descoteaux is try to understand or to describe the structural connectivity changes in patients with opercular insular epilepsy. So to do so, we recruited 9 patients with opercular insular epilepsy. It might sound like a low number of patients, but insular epilepsy is so rare that 9 patients is a fairly good number of patients. We had 2 age and sex match control group composed of 22 healthy individuals and 8 patients with temporal lobe epilepsy. All patients were scanned on a 3 Tesla machine using standard seizure protocol and a DWI voxel size of 1.8 isotropic. We used 60 direction of acquisition at B1500. In other words, we performed a single shell hardy high angular resolution diffusion imaging, which is the acquisition that's probably the best in order to achieve a proper and more specific FODF tracking. So this is basically the flow chart that we used. So starting from raw diffusion images at 60 direction of acquisition and using T1 images, we're able to in Maxime Descoteaux's lab, we're able to develop a cutting edge pipeline, pretty sophisticated, in order to create a connectivity matrices of all our patients, both for OIE, TLE, and healthy controls. And here you see the results of controls in patients with opercular insular epilepsy. So here you see the matrix once again on the y-axis and the x-axis that correspond to all the cortical regions, and every single point corresponds to the connection between two cortical regions. The color bar represent the commit weights, in other words, our marker of connectivity strength. So the more yellow is the connection, the higher it is connected. So you see some points that are hyper-connected between two different regions of the cortex. Grossly speaking, there was no macroscopic difference between controls in patients with opercular insular epilepsy. But statistical analysis has shown that in patients with OIE, so opercular insular epilepsy, there was a vast pattern of increased connectivity, as illustrated by the reddish the red connections here. And you see that there was a vast pattern of increased connectivity, whereas there was only a very few connections that were hypoconnected as compared to control. And this is to be expected because we know that in epilepsy, we have hyperconnections, and the insular network is probably very vast due to the fact that it's very vastly connected to every single region of the brain. When we actually compared patients with OIE and patients with temporal lobe epilepsy, and the goal again is to see if we can differentiate both types of epilepsies using specific types of MRI modalities, you see on the left side once again that both matrices, on left and right side, both matrices are very similar macroscopically speaking. When we looked at statistical comparison, there were more regions that were hyperconnected in patients with opercular insular epilepsy as compared to patients with temporal lobe epilepsy. And again, this makes sense because the network of insular epilepsy is probably vaster than the one of temporal lobe epilepsy, considering its high rate of anatomical connections. When we specifically looked at the network connecting the insula to all extrainsular regions, so there were 6 subinsular regions to all extrainsular regions, basically the whole brain except the insula, we saw that the FDR corrected result. There was an increase between the dorsal agranular insula, which is part of a portion of the insula, and the pregenual cingulate gyrus. In other words, the insula was hyperconnected to the anterior cingulate gyrus. And we know that the anterior cingulate gyrus is part of the network of insular epilepsy based on different functional studies that were previously performed. When we actually analyzed only the insula, so the insular subnetwork composed of only 6 different regions, that the insula illustrated in color on top right, you see here the connectivity matrix of 6 by 6 region. Again, looking at OIE and TLE, so to try to differentiate both, we noticed that patient had FDR-corrected results that showed an increased connectivity between the dorsal agranular insula and the dorsal granular insula. And this makes sense because we expect increased connectivity within the insula for patients with insular epilepsy, and we don't expect that for patients with temporal lobe epilepsy because the insula is not necessarily part of the temporal lobe epilepsy network. When we look at graph theory analysis, so basically graph theory analysis is the analysis or the study of topological properties of a graph made of node and edges. We noticed that in the insular region of patients with opercular insular epilepsy, there was an increase in degree and betweenness centrality. In other words, these are metrics that reflect increased connectivity within different regions, and it was increased in the region of the insula for those patients that had epilepsy coming from that region. So it makes total sense. Similarly, there was an increase in clustering and local efficiency. Again, 2 different metrics that in certain way reflect the increased connectivity. There was an increase in both metrics within the mesotemporal region of patients with temporal lobe epilepsy. And this makes sense because the mesotemporal region or the medial temporal region is part of the temporal lobe epilepsy network. So we're expecting results of increased connectivity within the epileptogenic network, respectively for OIE in the insular region and for TLEs in the mesiotemporal region. So the observed pattern of connectivity strength and whole network alterations between both types of epilepsies are potentially an additional tool to differentiate both types of epilepsies. So this is what, the conclusion that we had using this technique. So there's also a very interesting application. There are also very interesting application in epilepsy neurosurgery. So obviously we're trying to spare functional tracts in the same way we did for oncology neurosurgery. But we're trying to optimize cortical resection in the region that we believe are involved in epilepsy. And we try to optimize white matter disconnection in cases where we want to disconnect a specific tract. And this is mainly the case for patients that had focal epilepsy with easily generalizable epilepsies. In other words, secondarily generalized epilepsy coming from focus, but that generalizes to both sides of the brain. What's extremely interesting is that we can now identify surgical candidates that are most likely to become seizure-free just based on Connectome data coming from diffusion MRI tractography. So as I mentioned before, it can be used for the preoperative planning. This is an interesting paper that showed that patients with that were tracked, patients for which the Meyer's loop were tracked. This is the inferior portion of the optic radiation, Meyer's loop. Obviously, if you injure that region, you expect visual field deficit in these patients. You see a case here of a patient that had Meyer's loop that was completely preserved despite a temporal lobe resection, and the patient had no visual deficit, as opposed to another patient that had a cortical resection and had an injury to Meyer's loop that led to quadrant anopsia, meaning contralateral upper visual field deficit. In other words, if we track the visual fields, or the optic radiation, we're able to know or to guide surgical treatment as of how much cortical resection we're allowed to remove in order not to achieve any visual field deficit. It's also extremely useful for callosotomies. So callosotomies are basically disconnection between both sides of the brain. And callosotomies are mainly used for patients that have a focal epilepsy, so meaning coming from a specific region, but that rapidly generalizes to both hemispheres, both sides of the brain. So it becomes a generalized epilepsy. And by disconnecting both sides, patients will still have focal seizures, but would not have completely generalized seizures, which improves quality of life of these patients. So basically, we go and we disconnect by removing the white matter tract. So I'm going to show you a surgical video that was performed at St. Justine Hospital a few years ago. It's an endoscope-assisted callosotomy. Endoscope is basically a camera callosotomy in an 8-year-old boy that has what we call DWI syndrome. This patient had about 100 seizures per day. 30 to 40 were what we call atonic seizure. What's an atonic seizure? It's basically a seizure in which you lose all tone of your body extremely suddenly, and it's associated with drop attacks. So the patient drops on the floor, and you can imagine the concussion and head traumas that can be associated with it, especially when you have over 100 seizures per day. So it clearly affects quality of life of patients affected with this condition. So this was performed, a small craniotomy was performed instead of a big craniotomy in which we're used to see for callosotomies, and a small endoscope, meaning a camera, was inserted. So you're going to see the video here. So you see here the brain. This is the interhemispheric fissure. We're working between one side of the brain and the other side of the brain that's not exposed. So we're dissecting between both brains, both hemispheres. So basically the arachnoid adherences, so part of the meninges, are dissected right now. As you can see, we dissect the cingulate gyrus is actually mobilized laterally in order to make sure that we access the corpus callosum. So we're dissecting here the vessel that you see, or the pericallosal artery that control motor function of the lower extremity. So if you injure those vessels, you can lead to paralysis of the lower extremity. So you obviously do not want to paralyze the foot of a patient. Here you can see the corpus callosum that's starting to be dissected. So we dissect the corpus callosum here using the various instruments. We dissect more of the corpus callosum posteriorly. We make sure we don't touch the pericallosal artery to not cause lower extremity paresis or paralysis. And we make sure that at the end of the surgery, when we're satisfied with all the corpus callosum that's removed, using different instruments, we suction again. We use different types of instruments, and at the end, you can see that the whole corpus, the expected region of corpus callosum was removed, and you see the ependyma, which covers the ventricle that you obviously do not want to remove. So we're satisfied with the corpus callosum, the callosotomy that was performed. So the patient improved following surgeries in terms of both atonic seizure and other forms of generalized seizures. And tractography, again, can be useful after surgery. As you can see here in this specific example, you see the corpus callosum that's illustrated before surgery and is full. And after surgery, there's a disconnection between both sides of the brain because we disconnected the corpus callosum, and the disconnection seems to be complete. In this specific example, the right side, the preoperative corpus callosum is very well identified in tract, but after surgery, they noticed that there was a posterior portion of the corpus callosum that was remaining. And in this case, it was voluntary. They wanted to leave the posterior portion of the corpus callosum because in some cases, when you remove that region, this can lead to specific neuropsychological sequelae that you obviously do not want. But in some cases, the remaining of the corpus callosum needs to be addressed, and tractography can help us identify which parts remain connected. So that's extremely interesting. And finally, the diffusion MRI tractography is extremely interesting because it can help us predict seizure outcome in patients. So basically, this is a very interesting paper that was an interesting study that was done. So in this study, they only studied connections between the temporal lobe and the extratemporal lobe, meaning all many portions of the temporal lobe and portions of the extratemporal lobe. So outside the temporal lobe, all the regions outside the temporal lobe. And what you see here is the Z. What's illustrated here is the Z score of the number of streamlines of each connection. And what's shown here is that they counted the number of connections that were hyperconnected compared to control groups. And the more the patient had hyperconnected connection, the less likely he was to become seizure-free. So the number of links that are hyperconnected were not. So yeah. So the number of links that were hyperconnected correlated negatively with the probability of surgical success, and this is what was shown in this specific paper. So it's super interesting, and they were able to identify the specific links with the highest ability to predict surgical outcome. And using that technique, they actually created a score, and using only neural network data, so only diffusion MRI connectome data, they were able to pretty precisely identify which patient would become seizure-free after surgery. And the predictions were actually better than prediction based only on clinical variables, as you can see here. The combined data, however, of both clinical and neural network diffusion MRI tractography data was actually better in these patients. So that was very interesting that combining both data could predict outcome very well. This is just a similar paper that was done using machine learning. Actually, in this paper, they proposed a specific surgery, and using a cutting-edge pipeline, a very specific pipeline, they were able to predict whether a patient, according to a specific resection that was planned, if the patient will become seizure-free or not seizure-free. So you can predict which patient can become surgical candidates, and I think this is extremely interesting. So in conclusion, I hope I was able to convince you that the use of tractography and connectomics is clearly justified. It's very useful in oncology and neurosurgery. Okay, it allows to identify and spare functional tracts. It optimizes the extent of resection, and it might have some survival benefit. In epilepsy neurosurgery, it helps characterize and localize the epileptogenic network. It optimizes cortical resection or disconnection in terms of callosotomies, and can also identify surgical candidates with predicted seizure control, which is extremely promising. I have to say, however, that it requires users, both neurologists, neurosurgeons, researchers that have experience and knowledge of both the anatomy, the DMRI utility, diffusion MRI utility, and its limitation in order to perform such analysis. So I just want to thank you. It was great. It was great to work, and I'm still working at the Sherbrooke Connectivity Imaging Lab with Maxime Descoteaux, in collaboration with IMECA as well. All that was described in this specific talk can be performed at IMECA and at the Sherbrooke Connectivity Imaging Lab as well. If you have any question, if you want to contact me, collaborate, or just discuss, please don't hesitate to email me at my specific address. So thank you.
Thank you, Sami. That was wonderful. I would like to open up the floor to questions. So I see here that my first question comes from Maxime Descoteaux. His question is, diffusion MRI gives us a representation of structural connectivity, physical wiring. You mentioned the term functional tracts. Can you discuss this notion of functionality of tracts? For you, what is the dream measure of such functional tracts?
I'm sorry, did what measure?
For you, what is the dream measure of such functional tracts?
The dream measure. So basically, I think there's two ways of identifying functional tracts, either through functional MRI. However, the only way to specifically identify functional tracts is actually to stimulate it intraoperatively. In other words, we can rely on diffusion tractography to know where the tracts are. We need to stimulate during the operating room in a patient that's awake and see if it leads to neurological deficits or neurological changes. So I think the gold standard of identifying a functional tract is actually stimulating during the operating room.
Okay, great. So his next question is, what would be your dream diffusion MRI app at the MRI console in the neuronavigation system?
Oh, in the neuronavigation system, that's a very good question. Ideally, a neuronavigation system that can integrate. So let me start with the fact that most neuronavigation systems right now integrate only DTI tracking. So this is, more of a simplistic way of representing tracts. And I really hope that in the future we'll be able to integrate tracking or more sophisticated tracking, such as Hardy-based FODF tracking, like I mentioned before. In an ideal world, you could come into the neuronavigation system and just put the diffusion MRI images, T1 MRI, obtain the tracts, based on FODF tracking or more sophisticated or novel techniques, and actually see every single tract that you're looking for. So how do we do this? It's basically by making sure that we have specific tracts that we're looking for before actually performing the surgery. So identifying the tracts that we want, and then just feeding the diffusion MRI and T1 images and actually get those tracts based on highly sophisticated methods of tracking.
Okay, great. So his next question is, if you had a press button Connectome app, would you use it? If so, for what?
Yeah, so I would absolutely use it, specifically for epilepsy surgeries. So if I could press on a button and just obtain the region that, so the whole connectome, but mainly the region that are hyperconnected, it could definitely guide surgical treatment, because we know, as I mentioned, that epilepsy is it's a pathology that's caused by hyperconnectivity. So if we know which region are hyperconnected, you could potentially target those connections in order to improve seizure control after surgery. Obviously, we have to make sure that these tracts are not functional and won't cause neurological deficit, but it could be definitely useful adjunct for focal epilepsy cases.
Okay, thank you. If anyone else has any questions, please type it into the question box or raise your hand and I'd be happy to unmute you. Wait a couple seconds. Well, if there are no more questions, I'd like to thank you, Sami, very much for your presentation. It was very interesting. Thank you for your time. And I'd like to thank everyone else for attending today. And we look forward to seeing you at future webinars. So thanks everyone and have a great day. Bye now, Sami.
Thank
Bye
you.
everyone.